present on a little teaser of IDPH's new toolkits for implementing PPE in nursing homes to prevent the spread of MDROs and XDROs. And I think we have Karen and Deb on. Yes, so obviously, especially Karen, feel free to jump in if I'm saying anything wrong. But we're just going to do a little bit of it because they're going to present on it at their next roundtable or their next webinar. Then we have some exciting new projects and resource distribution updates we want to provide to you. Project Hope, Shelley's going to talk about that respiratory protection program. I think some of you have already joined a cohort, but there's a couple more cohorts coming up. Barb will do a presentation on audits and I'll provide some tools on that. Mark will do a little bit on emergency preparedness, and then we'll open for questions and answers. But as always, you are welcome to ask questions at any time. So this is the COVID dashboard. Things are pretty much the same. Hospitalizations, it said, went up from 18 to 18, but hospital beds, it's pretty low. ER visits are a little bit higher than they were, but it was 1.2% and now it's 1.4. The vaccinations, the arrow is up, but in red, so I don't really understand that part, but people aren't getting vaccinated that frequently anymore. We do really encourage vaccination with the most up-to-date version of the monovalent vaccine, and the staff, especially vaccination rates in a lot of your nursing homes are quite low, so please continue to promote those. This is the COVID case epi curve for skilled nursing facilities. So as you can see, we had a little bit of a blip going up and now it's going back down again, hopefully. So that's good. Only 35% of you have active outbreaks, and most of the outbreaks we have they're smaller than what they used to be. In terms of variants, the only thing I'm going to say here is that it's all still Omicron variants, so it's all within the same family. And can everyone mute because I'm hearing an echo? And in terms of the data tracker, I think we were in medium recently, but we're back to low now. So both low and medium, there's not really any changes you have to make. It's more in high. There's some additional recommendations, but it's good we're going in the right direction, back to low. And then respiratory virus surveillance. So again, this is a report that comes out every Friday during respiratory season from Chicago Department of Public Health with information on Chicago respiratory virus transmission. So there's nothing super interesting here to report. Things are going, again, in the right direction, where within the week ending February 10th, everything was pretty much lower than what it's been for the entire season average, except for seasonal coronavirus, which is different than COVID, went up a little bit. And then this is just some charts showing the trends. So as you can see, flu peaked already, and it wasn't as bad as it was in previous years. COVID, it kind of peaks and wanes. RSV peaked already, and everything else is good. So hopefully we're nearing the end of the respiratory virus season that wasn't as bad as it has been in the past. I'm not going to go through this. We just always include these slides. So no minimum routine staff or resident testing, but there are some situations where you should do staff and resident testing, like if they're symptomatic or during an outbreak or if they were exposed. And then, okay, again, Karen and Deb, feel free to jump in wherever, but I wanted to let you guys know, hopefully you received a siren alert with this link. I also have it linked on the slides that we'll post soon. It's also on our website, but there is a new toolkit that I know Karen spent a lot of time working on it basically talks about EBP, enhanced barrier precautions, and it goes into the details about MDROs and XDROs as well. So I'm going to, again, cover just the highlights of those, and I'm only going to focus on the part related to the MDRO, XDROs. I'm not going to go into EBP in general because we've talked about that a bunch on our webinars. So this is a new, really comprehensive toolkit from IDPH. There's tons of things in this toolkit. There's a slide deck you can use to train your staff. There are pre and post tests you can use to assess their competency on this. There's links, again, in our follow-up emails on our HAN page and then on this slide. So hopefully you guys will all be able to access it. We've talked about this before, but I just wanted to go over this again. So MDRO, multi-drug resistant organism, is kind of an umbrella term that covers what I refer to as all the baby MDROs, so like MRSA, ESBL producing bacteria, VRE, kind of the more run-of-the-mill MDROs. So it covers all of that, but also this subset that we call in Illinois XDRO. And it's kind of what it means is extensively drug resistant, even though C. auris isn't technically fall into that category usually. But anyways, when we're saying XDRO, we usually mean C. auris, CRE, crab, which is carbapenem resistant Acinetobacter baumannii, and then CP, usually RPA, but Pseudomonas as well. So those are what we mean when we say XDRO, and those are all organisms that would be in the XDRO registry. So hopefully you guys all have access to that. For those of you who don't, hopefully you've been hooked up with Tasa, who's one of my teammates who can help you. And if you have no idea what I'm talking about, then let me know and we can reach out afterwards. But so the XDRO organisms are the ones I guess the O is organism, but the XDROs are the ones we really are more concerned about in nursing homes. We have seen a big increase in a lot of our SNFs, especially. V-SNFs have always had a lot of issues with XDROs, but we're seeing more in our SNFs. And once CORIS specifically gets into a facility, it's really hard to control. So that's why enhanced barrier precautions and querying the XDRO registry are really important. So we'll go through a little bit of that. And thanks to CC, my teammate, who made this little diagram. So again, IDPH, please correct me if anything I'm saying is wrong. For MDRO, so again, when I say MDROs, I'm talking about the more baby ones, MRSA, VRE, the more common ones. You can use a risk-based approach to determine if you want to put them in any precautions at all, if they're colonized or infected. So you could put them, like some places I know put people with MDROs, if they're active MDROs, they put them in contact precautions. Some will put them in EBP and some put them in no precautions. What you should do is use that risk-based approach to see, like, if everyone in your entire facility has MRSA, then and you're starting to see more of the XDROs, you might want to focus more on those. You should also use the resident's clinical situation, the prevalence in the facility or in the community at large, to determine whether you want to put them on any type of precautions. Although, as always, with every single resident, you should use standard precautions. The exception to that would be any residents with secretions or excretions that cannot be contained, regardless of whether they have MDRO or not. Like, for example, a draining wound that can't be contained, they need to be on contact precautions for a time-limited period where until that wound, that drainage can be contained. So that's always an exception to anything I say. There's times where you'd have to escalate the precautions to contact precautions based on the person's situation, and then you can go back to enhanced barrier, or if you decide for MDROs you don't want anything, you can do that as well based on this risk assessment. Oh, good. Karen's saying the toolkit also includes how to access the XDRO registry, so that's helpful. And then we did, I think it was the last roundtable. It was the last one or the one before that. Tasa did a good presentation about XDRO as well. So, and all those slides from our webinars and the IDPH webinars are on our website, although they're difficult to get to. So for XDROs, again, those are, let me see if I can move back. These little baby, not baby, these are more serious ones. So CORS, CRE, CRAB. Those, you really need to put them in some type of precautions. So EBP is okay. So they should not be in just standard precautions. Like a resident with CORS should not be in standard precautions, even in a VSNF. The precautions that you put in place are in place for the duration of their stay at the facility. So it's not like contact precautions you would do for scabies, for example, where you take them, or C. diff or something like that, where they're just on it for a little bit. They're on precautions forever at your facility. Even if they go to the hospital and test negative, like it can be intermittently positive. So that's why EBP is important, because it still allows them to live their life in the facility without being restricted to their room forever, like contact precautions would. And like I said, it's the least restrictive option, so that's why it's the best option. Okay, if ESBL not an XDRO club pneumonia, what precautions do you suggest? So again, IDPH or here or anyone comment, but if it's an MDRO like those, and you do a risk assessment, like if it's at one of your facilities, for example, that's a VSNF that probably, and they have other situations going on, you could potentially determine that, this isn't something we're going to focus a lot of our resources on, so put them in standard precautions. If it's other facilities where they don't see as much, then they can do, you can do a higher level precautions like EBP. Karen and Deb, does that sound okay? Okay, yeah, they're saying risk-based.
Couldn't find my
okay.
tests.
Okay.
That's fine. So, and I'm going to go into that a little bit more detail tomorrow too,
perfect.
Lauren, as far as the ESBLs and some of that. Hopefully it'll clear up the confusion.
Yeah, definitely everyone make sure you're registered for the webinar tomorrow if you aren't already, and we can, maybe one of the IPs, like Steph V, could you drop in the registration for that for tomorrow so people can click on it and join? And then Mark said for a resident with an MDRO that's contained like VRE and the resident where it's brief, would we just implement contact precautions during incontinence care only? Or if there's, yeah, I feel like if it can't be contained, like if they're having, then it would be contact precautions. But I don't know if you need to do, like, I'm assuming if they're doing incontinence care, like changing briefs or stuff, it would be like they'd be wearing a glove and gowns as part of standard precautions, correct? I don't know if I'm understanding your question right, so feel free to come off mute, Mark.
Sure. So thanks. So I mean, standard precautions would be used without a gown necessarily if they're doing incontinence care. If the person didn't have diarrhea or something, it was just standard incontinence care. You'd just be using gloves, but not a gown.
Yeah.
So would someone with, VRE, while they're getting incontinence care, should they staff also wear a gown? Or if we don't think that it's really prevalent, and we could just go back to just gloves.
Yeah, I mean, again, I'll defer a little bit to IDPH, but I think in that situation, if you guys have done that risk-based assessment and not determined that VRE is something, that it's, prevalent in your community, or based on the clinical situation, you don't feel like it's something you want to put someone on EBP for, then I think just standard precautions would be fine. So if gloves is what you're using, that'd be fine. But again, if there's risk of like fecal matter getting in other places, then you might want to wear additional PPE. I don't know if that answered the question.
Yes, thank you.
Okay, perfect. And then, okay, good. Deb agrees with me. Great. So similar exception. So this is like slightly different than the other example, but any residents with secretions or excretions, again, that can't be contained. So similar to what I put down for MDROs, but another example would be like a resident with acute diarrhea, regardless of whether you think that diarrhea is related to their MDRO or XDRO infection, or really any infection, they should be placed on contact precautions. Okay, great. Stephanie just pasted the link for the IDPH webinar going over this toolkit tomorrow. So if you haven't already signed up for that, click on that link and you can register while you're listening to me talk. And then this is what I have, my number one thing I've ever learned from Deb is whatever you decide to do, make sure your practices align with your policies so you don't get tagged. And then this is also in the toolkit, so it's a helpful kind of flow chart. The one other exception, and sometimes we tell you you have to do this, and sometimes you might determine this on your own, is that if there is a unit of your facility, like let's say you have never seen CORIS in your facility before, and then you're starting to see a bunch of cases, we'll be in touch with you and we'll work with you on that. But let's say we had a situation where there's number of cases on the same unit. What we did is we put those people on contact precautions for a little while that outbreak was occurring until we could figure out and stop the transmission. So that might happen where even if your general policy is to put people with XDROs on EBP, there might be some, again, time limited situations where we're going to tell you, we really want you to put them on contact precautions because the transmission is ongoing and we don't really know what's going on. But if it's, and then some places like VSNFs, for example, it's kind of always ongoing transmission. So you got to, like, pretty much all of our VSNFs have a lot of XDROs. So you wouldn't necessarily put them all on contact precautions forever. This is more, the way we use it in Chicago would be more of a SNF that hasn't seen this as much before and is having an acute issue. But let's say there's not ongoing transmission that you're aware of. So you and again, the beginning of this is someone who has an XDRO or MDRO. So that's the base of what we're going with. So if they have any of the other indications for EBP, you would put them on EBP. So again, a wound. If they don't have any of the other indications, you would just put them on EBP. But even if they do have any of the other indications, you would also put them on EBP. So if there's an indwelling medical device and they have the XDRO, you put them on precautions. If they have acute diarrhea, like I had said previously, they would go on contact precautions until, again, that acute diarrhea resolved, and then they could go back on EBP. If they have wounds and they can be covered and contained, you just do EBP. And if they can't, then you would do, again, that contact precautions until the wound can be contained. But the main point of this flowchart is to say, basically with an XDRO or MDRO, again, you use the risk assessment for the MDRO, but for an XDRO, there should never be a situation where they're not on enhanced barrier precautions. And sometimes they would need those additional precautions depending on the situation, like the wounds or acute diarrhea or wounds that can't be contained. Okay, sorry, I did not do a great job explaining that. Hopefully Karen will tomorrow. So cohorting, again, Chicago sees a lot more of these XDROs than a lot of the other jurisdictions in the state. So this is important. So the main thing is do not put someone who has known XDRO colonization or infection with someone who doesn't. Especially if that other person is immunocompromised, has a wound or indwelling device. There should really be no situation where you have no beds available, so you have to put someone with CORIS in a room with someone who doesn't have CORIS. Like the only time that potentially would happen, and even then we're going to probably say we recommend closing to new admissions, would maybe be in a VSNF. But in a regular SNF, I would be shocked if there was ever a situation where you're in such a crisis that you had to put someone with CORS with someone who didn't have it. So that is the number one important thing. Don't put someone with a known XDRO with someone who doesn't have one. So there are situations where, especially in, again, like a VSNF, where you just have tons of XDROs around. So if they're endemic pathogens, like let's say you have someone with crab who has the OXA23 mechanism, and then someone else who has crab with the OXA20, 2440 mechanism, those are both pretty endemic. They're both crabs. So in that situation, we would be okay if you put them together. Again, it's always best to put people separate, but if you put them together, that would be okay. But you should not cohort those people with people who have other types of organisms. The next one, the second one is the identical rare or low prevalence pathogens. So for CRE, things like I know, and we talked about this last time, so hopefully people remember a little bit, but the NDM or VIM, the NDM can be with NDM, the VIM can be with VIM. We do not want you mixing someone with CRE with NDM with someone with CRE with VIM. Those are the lower prevalence ones. We do not want to create these even more of super bugs in Chicago. So really keep those separate. They can cohort only if they have identical mechanisms. And then you can also cohort residents who have CORS but no other XDROs. So if you have, two people that have CORS, they don't have anything else, they can get cohorted. The only exception, and again, this happens a lot in VSNFs, where a lot of people have CORS and a lot of people have other things, and there's not a lot of bed space available. So if you had CORS and CRE NDM, you could go with another person who has CORS and CRE NDM. But we want to put a CORS CRE NDM with a CORS CRE VIM. I know I'm just saying a bunch of letters and people are probably confused, but you can always go back and look at the slide. If people have questions, just throw them in the chat. So we've done this slide, I think, on another roundtable, but I wanted to pull it up again. So this is a fake floor plan that I think CC also made. She makes all of our graphics. So let's look at it for a second. I don't know if you can see the room numbers or if it's too small, but there's a couple issues here with cohorting. So we really recommend you do these kind of floor plans, and we can help you if you need it. Like if you have a lot of XDROs in your facility, we can help you make these plans. And it's really easy if it's color coded to see where there's issues. So in room 206, for example, both of those people have crab and only crab, so they're cool. They can stay together. In room 207, just to go to the legend a little bit, the light colors means that they're previously known and the red means they are newly identified. But in room 207, one of the people has crab and two of the people don't have crab. So that person really should be moved. In 208, same thing. One person has crab, one doesn't. You could switch those together if you wanted. And then the other issues are room 215 at the bottom right. That person has CRPA VIM and they're with two negative people. 216, same thing, CORS with a negative person. 201 is okay because they're CORS with nobody with them. And then 202 is an issue, even though both of them have some kind of XDRO. One has CRE KPC, the other one has a CORS and CRE KPC. They would need to be separated. So even though they both have CRE KPC, the person in the bottom bed also has CORS, so they need to be separated. Again, I know this is confusing, but you'll have these slides. So an ideal situation, this is the before, and this is after. So as you can see, the main thing to look at is, do all the colors match in the rooms? And then if they don't match, is the other bed empty? But kind of, that didn't really make sense. But so see how the negatives are together now. Only the positives of the same organism are together. So in room 201, for example, there's two CORSs. The guy who has two things in room 202, he's by himself. So if you can, again, kind of look at those maps, but for those of you who have a decent amount of the XDROs, this is really the best way to cohort. And again, we can help you with that. And then, so if you're admitting a new resident, like you're taking this seriously, you want to start implementing EBP and you want to make sure you're doing it correctly. Again, it's really important to know if someone has an XDRO before they come to you, because then you can immediately place them into the appropriate precautions, which would mean they hopefully would not transmit to others. So if you want to do that, you should really query XDRO, the Illinois XDRO registry. If you don't have access to that, and I know it's been taking a long time to get access and there's lots of bumps along the way, but Tasa and our team can help you. So make sure you contact her if you haven't already. One important thing about XDRO is it only has information on people who have been tested and were positive. There is almost certainly, well, not almost certainly, I know there are people who have XDROs that are not in this registry because they've never been tested, because testing for XDROs is not usually routine, except for in a couple facilities, like some of the hospitals And VSNFs will do admission screening where anyone who comes into that facility gets screened, or discharge screening, but that's not standard practice at your SNFs, for example. You're not screening everyone who comes in for an XDRO. So that registry only contains those we know about. There's many that we don't know about. So just because they're not an XDRO doesn't necessarily mean they don't have an XDRO. But if they are in the XDRO registry, that means they do, and then you should put them on EBP. And again, similar to the residents remaining on EBP forever, if they have an XDRO, they will also remain in that registry forever. So if they're in that registry, please place them on enhanced barrier precautions and cohort them appropriately. And then just here are some additional resources. So again, they have that pre and post test. There's a competency validation form. So I know Karen will go over all of this tomorrow, but it's a really great toolkit and we're very excited about it. Now, switching to more swag we have for you guys. We have purchased a lot of air purifiers. These are going to go to the SNFs and the VSNFs, assisted living facilities and supportive living facilities. I can't remember off the top of my head. I don't know if Janice is on. Janice is on. Janice, do you remember how we're doing this? Are we giving a certain number to each facility? Sorry to put you on the spot.
Oh, no worries. Yes, we had 3. We had
3. Okay. So each of you will be getting 3 air purifiers. So what we're doing is we gave the addresses, the main phone numbers, and the administrators' names to the company that's going to be distributing these air purifiers. So if you're administrator, like Mark, for example, you might come in one day and there's just 3 big boxes for you. So you're welcome, but those are free air purifiers from us. So if you see these gigantic boxes, that's what's going on. You might want to notify the people who work at the front desk that some delivery will be coming. I don't know if they're going to notify you guys in advance, whoever is delivering it, that it's coming. Yes, Christy.
I was just going to add that we're sending you also a 5-year supply of filters.
Oh, okay. Yeah, Christy's volume's a little low, but she's saying that we're also sending 5-year supply of filters. That's a lot of filters. So yes, you'll be able to use these for 5 years with the filters we send.
It's 2 filters a year for each unit. So
perfect. Okay. So yes, we're setting you up with this. Definitely please put them in areas like communal dining areas, activity rooms. If you're having an outbreak of a respiratory pathogen on a particular unit, please move it there. And again, these are free. And if you have any questions about them, Janice, I have her email address there, so please reach out to her. But they should be coming, I think, relatively soon. I don't have the exact date, so just keep a lookout for that.
Yeah, I don't think we have a date as of yet. And as it gets closer, we'll let people know, I would think. And any questions on using them, feel free. We'll probably come up with some handout on it also.
Yeah, so that's an exciting thing that's coming soon. And then the other thing we're going to do, I know those of you who have been in your roles for a couple years, hopefully remember when we did focus groups for staff who have been vaccinated but not yet boosted, to find out kind of the reasons behind the hesitancy around that. So we're doing a similar style thing, but this one's not vaccine related. This is related to CNAs and CNA retention, because we know there's a ton of turnover amongst CNAs. And then when CNAs leave, they're taking that institutional knowledge with them. Then you have to train new people who might not be as well versed in infection control. So we're trying to find out kind of motivators and detractors to staying at their jobs, mostly non-financial. And then we're going to do those focus groups and then share those results with you like we did last time. So the focus group participants, they have to be CNAs in a nursing home. They'll get $75 to participate. I'm hoping the recruitment will go a little bit better this time, because last time I think people thought we were tricking them into getting the vaccine. But it'll be the same way, where it's anonymous text-based platform. They can do it from their phone or from their computer. So we'll be distributing recruitment materials to you guys in about a month.
Roundtable, yeah.
Oh, sorry, if you guys could all mute. We'll be distributing those materials to you in about a month, and then we'll encourage you to share with your CNAs. Unfortunately, we can only have, I think, like 25 or 30 people per group, so it's probably going to fill up pretty fast, and we're probably going to ask the people who make that screener survey to cap it at 2 or 3 people per facility, so we get a wide range. But we will share that with you, and definitely encourage you to share that with your CNAs. And then the IPs will also be asking for your input and thoughts on the next round of follow-up calls, because we have talked to a couple DONs and administrators at various facilities, and they've given us some good ideas of what could potentially increase retention. I think that might be it for my part for now. Yes. Okay. So I'm going to pass it over to Shelley from Project Hope for a couple minutes.
Thank you so much. really appreciate the opportunity to update you all on the respiratory
Oh, we got
protection
this.
program. Next slide, please. As a reminder, it's just kind of stuck there. I can't move as quickly as you do, Liz. You're a faster thinker. I will move quickly on this because hopefully it is just an update and a little bit of new information. So as a reminder, this is the OSHA standard that Project Hope was fully funded with an award to help long-term care facilities come into compliance with the OSHA Respiratory Protection Program standard. We're doing so by way of virtual training programs, one on-site fit testing, train the trainer program. And then an important aspect is procurement. We're actually procuring equipment, supplies, medical evaluations, all depending on the assessment of each facility. Each facility participating in the program conducts their own self-assessment, and then the facility lets us know at the end of the 6-week session how we can best bolster their written RPP and the implementation of their program. Next slide, please. We've put together a business case because we know that everybody's time in the building is precious, and you have a lot of competing interests and priorities. So I want to be super clear here. On the left-hand side, these are labor hours that your people would invest in participating. Very minimal labor hours, but we tried to put dollars to it because we've been talking with corporate offices to help them understand on a large scale, what's the return on investment if their facilities participate in the program. You can see the investment is very low. This is a no cost program to the facilities. It is fully funded. On the right-hand side is the return. Not only is there free training and consultation provided, but there's also the cost avoidance, which is huge if OSHA does cite. Their citations are really hefty from a financial perspective. So that's cost avoidance built into the formula. Of course, there's the goodwill from a marketing perspective and the reduced lost time for both staff as well as residents, because we know that staff safety and resident safety are inextricably linked. Next slide, please. The procurement aspect of the program, what we've really boiled it down to, and I'm so glad to see that you guys are providing air purifiers for the buildings. Just recently, I conducted an literature review because initially the information that came out at the very outset, there was mixed reviews about whether or not portable air purifiers were in fact helpful. Now there's very solid evidence supporting the use of portable air purifiers in addition to other aspects of managing indoor air quality. So we are offering small air purifiers, the kind that you might place in a resident's room between the resident and the door if that is a resident that is testing positive, but you're not able to keep the door closed safely to filter the air before it goes out into the common areas. You all are providing the large air purifiers. We will supplement that for your facilities, or we could shift. This is totally at the request of facilities. You may want to request more small portable units that can be moved from resident room to resident room. Fit test hoods, replacement solutions. Most of the facilities we're talking with do not have any PAPRs stocked. The PAPR units come with 5 disposable hoods that you can deploy to each employee, 1 hood per employee with 1 fan unit. And medical evaluations are above and beyond the other requests. If you have a facility where you've fallen behind on your fit testing, which many have over the course of the recent years, we can request medical evaluations from a turnkey partner and pay for those for the facilities. So this is just an example of some of the requests on the left-hand side of the slide, some of the requests that are coming in for support for the implementation aspect of the program. Next slide, please. We also are looking at, we have 2 more sessions planned. Cohorts 5 and 6 were targeted for the rural and outlying areas. So we're doing the in-person session in Rockford for the sessions beginning March 5th and 6th. However, we are allowing Chicago area facilities to fill those sessions as well. We will accommodate requests to be in the March 5th and 6th sessions. This is the registration link. Next slide, please. The next session and the final one is beginning in May, and that will be a Chicago area session where the in-person is in Des Plaines. For any corporate staff, where you have a very large number of buildings you're dealing with, if you're interested in talking about a corporate specific approach to the training, please contact me. My email is here on the slide, and we can talk about how we tailor it to the needs of your buildings. I've had some people approach me saying, we already have an RPP, but we need to update it, need to be sure it's compliant in all of our buildings. How can we kind of shortcut the process or gain credit for current experience or previous learning experience anyway? So we can tailor it to your buildings. So please contact me. And any questions, also email me and I'm happy to respond. Again, thanks so much. Appreciate the time.
Thank you. I think next we might have Barb. Let's see. Yes, so I'm going to pass it over to Barb Brown, who's one of our newer infection preventionists. She's going to talk a little bit about auditing.
Good afternoon, everyone. Let's talk a little bit about auditing in infection prevention and control practices. What is auditing? Auditing is a quality improvement process of conducting an impartial study of specific practices in infection prevention and control. Auditing in healthcare measures healthcare personnel's adherence to standard and isolation precautions, sterilization, environmental cleaning, and disinfection. It can also be used for other practices as well. Effectively implemented audits provide relevant information for progress. Next slide, please. Plan your audit process. You want to schedule a time and a date. Determine what infection prevention and control practice you will observe healthcare workers practicing. Check resources available. What tool will you use to document and audit results? Decide how you will share those results. Next slide, please.
Oh, did it not? Are you not seeing the why are audits important? Oh, everyone else, Barb, everyone else can see that one. What is on your screen? Oh, okay. Barb lost her connection, so we're just gonna move her to a different computer. So please hold. Sorry, they're finishing up getting her on the other computer.
Sorry, everyone. Why are audits important? Audits are important to increase accountability and improve the quality of care in healthcare facilities through systematic monitoring and evaluation. Next slide, please. What should infection prevention audits include? Infection prevention audits should include assessments of adherence to protocols, policies, and the basic infection prevention practices and safety in a healthcare environment. Next slide, please. Audit method. What floor or unit is being observed? Are healthcare workers following the policies and protocols? Are supplies accessible? We mostly see infection prevention and control observations of healthcare workers' hand hygiene, environmental cleaning, and donning and doffing of PPE. However, there are other practices that can be audited. For example, is shared equipment being cleaned between the use of patients? For instance, blood pressure monitors and stethoscopes. Next slide, please. Preparation of an audit team. Audit champions are an important part of an infection prevention and control in a healthcare setting. Audit champions consist of healthcare professionals who are committed to implementing change, act as role models for the intended change, and are eager to convince others in the organization of the urgency of change. Next slide, please. Here is the plan, do, study, act cycle. Plan for improvement. Do, implement interventions. Study, audit processes to study impact. Act, modify or re-educate if needed. Next slide, please. Let me just say one more thing about the plan, do, study, act cycle. You can use audits to determine whether an intervention was successful. For example, if you were thinking about installing additional alcohol-based hand rub units, and you want to know if that would lead to an increase in hand hygiene compliance, you can conduct audits before and after the additional units are placed to see if your hypothesis was correct. Now here comes the fun part. Next slide, please. Question 1. To increase hand hygiene, in what phase of the PDSA cycle would we implement the intervention? You can put your answer in the chat. The first person to answer that is our champion. What's this thing? Can you hear me? It kicked me off again.
No, we can hear you. We can hear you
Okay.
still. Okay, so I'm gonna give you guys hints. I'm going back to the last slide. So at what stage would you actually do the intervention? It's
Come on,
good
guys,
job,
you got
Amy.
this.
Yeah, Amy's got it.
Okay, great job,
Alden
Amy.
for the wind. Okay, or the wind, not
Yay.
the wind. Okay, I'll move forward now.
Okay. The do phase, yes. Next question. Your facility is having an outbreak of C. diff. What type of practices could you audit to ensure staff were following the appropriate protocols? Just throw in some answers.
Yeah, there's a bunch of answers here.
Okay, hand hygiene, that's great. But hand hygiene, oh, I can't give the answer. Any more? What else could we do in a case of an outbreak of C. diff? What other practices can we use to try to halt this? Soap and water. Yes. What else? What else can we do? Oh, okay, Liz, you want to go to the second slide? Okay, here we have it. Glove use, gown use, changing your PPE, hand hygiene with soap and water, and cleaning with a K agent. Next slide, please. Examples of content that should be included in training and assessed during auditing, depending on the area being assessed. Infection prevention and control auditing is a great opportunity to assess gaps in compliance of standard practices. Also, auditing allows for benchmarking of healthcare workers' practices across different departments. Provide prompt, regular feedback on adherence and related outcomes to healthcare personnel and facility leadership. Next question, please. Next slide. Sorry. How observational audits improve infection prevention. The goal should be to do a whole house surveillance by location, job title, and shift. This will determine what areas in the healthcare facilities need further attention. Next slide, please. Here are some examples of who can conduct audits. IP, department managers, secret shoppers, nurses, and volunteers. Next slide, please. What is one of the advantages of using secret shoppers to conduct audits? Who is our champion on this question? Okay, great. So if staff know that they are being watched, they are more likely to change their behavior, right? And vice versa, if staff do not know that you're watching them, they are more likely to behave as usual, right? So secret shoppers are the ideal auditors, as if staff don't know they're being watched, they are more likely to behave as they normally would. And thank you, that's all for me.
Thanks so much, Barb. That was great. And I like the person answering first as the champion. It was a good motivator. So here's a bunch of the references she has from her various slides. And again, all the references for what we talk about are on the bottom of the slides as well. I'm just going to go quickly. I'm not going to go in detail through some of the tools that you could use to audit some of the practices Barb mentioned. Oh, this is her thank you slide. So one thing, I know not all of you do CHG bathing, but a decent amount of you, I would assume, do some kind of bed baths for at least some of your residents. So you could audit bathing practices. We know in skilled nursing facilities, a lot of times certain parts of the bodies are missed. So that's something you could audit, especially if you're training new CNAs or new staff. You can audit them after they've received their initial training, and you can do periodic audits after that. Then there's hand hygiene audits. These are just a couple examples. There's a million out there. But so hand hygiene observations, you can do specific things like inside the room. Are they doing it before they're touching a resident, before they're performing an aseptic task? And then you can also do it outside in the hallway. Like, are they performing hand hygiene when they go in, when they come out, things like that. PPE audit. So this one's helpful as well, especially for those of you who have people on transmission-based precautions, including enhanced barrier precautions. I'm not really sure what enhanced respiratory is. Maybe that's COVID. Sorry, I'm just reading the form. So you can do these audits as well. So if someone's in contact precautions, for example, they should be putting on a gown and gloves before they even go into the room. So did they actually do that? And you can have the role right here and whether it was upon entry or exit, whether they did hand hygiene. So this is really helpful to use these standardized tools because then you can aggregate the data and present back. So you can be like on the second floor, 75% of the staff were observed to follow the appropriate hand hygiene practices. But on the first floor, it was only 30%. And then you know that you can work more on the third or the first floor and give some more props to the second floor. And then there's other things as well. So if you're trying to work on CAUTI prevention, you can look at indwelling urinary catheter insertion audits. You can do wound care audits. There's tools for everything. So and then EVS as well. And again, we gave all of you those glow germ kits. So definitely recommend using those for the EVS audits. You can mark certain surfaces in the patient's room or even in common areas, have the housekeeping staff clean it, don't tell them what rooms you're marking, and then go back and see if it's still there. And that can also help with providing training and real-time feedback. Okay, I think our last part is Mark, so I'll pass it over to him.
Thank you, Liz. Good afternoon, everybody. For those of you that are hooked up with Han, you should have received an alert Tuesday. about a project that I'm working on this year, and that's to visit all of the long-term cares in the city. The email or the alert should have come with an email that has a link where you can schedule your own times and dates. I will see that and will make the correct and proper plans. If you try to sign up for a time or date and you're not allowed to, chances are it's because it's already booked or there's something else going on and I'm not available. Again, I want to let everybody know that we here at CDPH do not have any teeth. We are not looking to cause you any trouble. Quite honestly, we're trying to help you comply with the IDPH e-tag surveys. So I'm here to help, even though I am from the government, as the old joke goes. Please sign up. If I don't get people signed up, I will start setting up plans to show up on my own. That's it. I will put my email in the chat for those of you that have not gotten the alert, and you can drop me an email and I will reply with the letter, and then you can then sign up from that. Thank you very much.
Thanks, Mark. Okay, I think that is it. It is it. So I'm excited. Next month we're having someone come on to present. She's a great speaker. She was doing, so we have a counterpart, my counterpart, Maria, at the health department. They do their own roundtable for acute care facilities, and she came on and presented there, and it was fantastic. So we asked her to present here. So she will be presenting next month. So we're very excited about that. Does anyone have any questions or things they want to mention? Otherwise, we'll give you some time back. Hearing none, hope you guys have a great rest of your day and enjoy the nice weather. See you.